my class. How often does that happen? First attempt, I'm on there.
That's extremely unusual.
I know, tell me about it.
The blessing of the rain. Huh?
Yes. Morning.
Morning.
First, are there any questions or concerns?
No.
Okay. Becky doesn't have any. Does anyone else?
No.
Okay.
I would have to say I was excited when I signed up for my next set of labs that you were one of the instructors.
I know. I wasn't, I was told initially that I was teaching 2 sections of 121. And then I talked to the bookstore and found out that no, that wasn't the case. And so, yeah, it was a little, but I'm excited. It'll be interesting because it'll be the first semester I've ever taught that course.
Yeah,
can't-
so
Yeah, we'll see.
I signed up.
What
I
class
saw
is
your
that?
name on there.
What class is that?
122.
Which is what?
It's the next class after this.
Oh, okay.
Yeah, it's almost this exact time.
Yeah.
isn't it?
Yep.
Yeah, off by a half hour.
Oh, really? Wow.
Yeah.
That might work well for me too.
Wendy, if you want into it, let me know because right now it's full.
Oh,
But the perks of online classes is there's no cap.
oh,
If the professor lets you in, the professor lets you in. But do
Okay.
me a favor if you decide that that works for your schedule, because it's going to be it's all day course, so it's going to go until 8 in the morning until 2:40 in the afternoon, essentially.
okay.
It's the
And that
same
was-
setup we have now.
Okay.
Is it?
Yeah, because after you, we have a little bit of a break and then we do the lab portion with Dr. Wicks.
Right.
So it would be the same setup because you're doing the lab as well, correct?
Uh-huh.
Yeah,
Yeah.
it's the same setup that we're doing right now then.
Okay. So yeah, if you decide you want to, if that works for your schedule and you want to be in that class, send me when you send, because I'll have to override, which isn't actually really easy.
Yeah.
But let me know, and also send me your student ID number when you do.
Okay. Can you just tell me, is it 122 dash whatever number? Do you have that?
I think
No.
it's 122-000.
Okay. Just so it's easier for me to find.
Yeah, I understand. I think
Thank
that's
you.
what it is.
Thanks.
You're welcome. Content. And of course, I didn't transfer it over. So we're going to finish chapter 13, and then we're going to start chapter 14 and make it through a good part of chapter 14. Bear with me just for a second.
Professor Jessel,
Yeah.
so yeah, I was gonna ask that this morning. The email that you and I had emailed back and forth,
Uh-huh.
thank you for that. That made sense to me. But then last night I was going through the chapter 13 practice.
Uh-huh.
That is And then I realized I was like, oh gosh, I'm like kind of confused again.
What?
Was that getting pushed back like another week since we're finishing? Like,
Yeah,
finish-
and you know what? What I want to do is as soon as we finish chapter 14, I'm gonna open the second exam.
Okay.
And that's when that one will be due. The practices, I like to leave them open, and I may stop doing it because there's been so many questions about it after this semester. But I like to leave them open until the first exam.
Right.
Or the
Okay.
exam of those chapters. And I
Okay.
may stop doing that after this semester because it just seems like it's more of a headache.
I think that the only thing that's really been confusing me, because when I go into like our portal and I'm looking at things that I need to do, I'm looking at like over on the right hand side, it just gives you, the practices, the quizzes, and everything that's coming up, and it gives you the dates.
Right.
So I'm following that, but I know that sometimes things get pushed,
Right.
which I understand, but then those dates sometimes don't change or adjust.
I don't know why they don't do that. That's a
Okay.
problem with D2L and
Yeah.
Connect, McGraw-Hill.
So, okay. Yeah, that's actually what has been my major problem, because I use that to try to keep
Understand that.
myself on track. And then I
Right.
get totally freaked out and I'm like, oh my gosh, like, was I supposed to do this? Like now it's past it. Yeah. So I don't, that's been my confusion. And that's why I texted you and I was like, is this actually due or is this not actually due?
Yeah,
Because
I
then I
don't,
worry and I think I'm falling behind.
yeah, and I don't know why they're not better connected there.
Okay. Okay.
But I'm not sure if it's anything that I can change either.
Oh, okay.
Does that make sense?
Yeah,
If
no,
they're,
that makes a
the
lot more
fact that
sense.
they're not coupled better and the dates aren't changing when I change the dates on D2L,
Right.
I don't know how to fix that. And it may
Okay.
be that they just aren't going to. Does that
Okay.
make sense?
Yeah, no, it does make sense. At least I just confirmed that with you because it was just like freaking me out. I'm like, oh my gosh, like I keep
I can understand. I think if I redeploy it, if I change the date and I redeploy it, sometimes it assigns it twice.
Yeah,
And
I
that
saw
isn't
that
gonna
happen
work
once
either.
before.
Yeah,
Okay.
I have had it assigned twice and that doesn't work. Because then
Right.
everyone's like, haven't we all, didn't I just do this? Well, of course you did. Yeah.
Okay.
Moving here. I think we were right here. If irritated, this nerve will cause hiccups. You know what nerve it is? I know it was a week ago, but what nerve is it?
See,
Mm.
Why do you say C?
I don't know. I really thought that's what it was.
Well, you're right, but why do you say C?
Well, because I was listening and I remember that's what it was. I don't know why. I just know I was listening and I'm
It's-
pretty sure that's what it was, but I don't know the reasons why, Mary.
You're right. It's the nerve. It's the nerve that's going to innervate the diaphragm.
But I've been watching about this at work when people have hiccups. I'm like, ooh.
See, you gotta love anatomy and physiology.
Yep.
All
Well, I
this
have to-
stuff you learn.
I have to say, I had to have my crystals realigned in my ear because I had vertigo this week.
Oh, really?
Wow.
Yeah. So at work, because I work at the hospital, it's been affecting me for a while. And it was really, really bad. And so I was trying to figure out what it was. And I talked to one of the nurses and he was like, I'm pretty sure it's vertigo. Get your crystals realigned. And I was like, okay, yeah, whatever. Well, yeah, they really are crystals.
They are. They're called
Yeah.
they're called otoliths. And you know what? When we go to the special senses, and hopefully we're not going to run out of time this semester, but when we go to the special senses, I talk about hearing and balance. Well, I have to pick, I'm supposed to pick one. And because I'm hearing impaired
Mhm.
and I know the most about that. And so I was told to pick a special sense that I know the most about, and that's the one that I do.
Yeah, it really was the strangest thing. I thought, okay, yeah, whatever, just give it a whirl. And lo and behold, it helped.
What did they do? Can I ask?
Yeah, it's the physical therapist at the hospital. You sit up and you turn 45 degrees one way and you sit there for a minute. And then all of a sudden you go back really fast. Like you're kind of
Okay.
on a table and your head hangs off. So then you go back really fast, still staring at that direction.
Yeah.
You stay that way for a minute. And then you get up, do your bearings, turn to the other direction 45 degrees that way for a minute, and then you fall back again, stay that way for a minute, and then you roll and stare at the ground, so it like realigns everything in
Right.
here.
Right.
I thought, oh, okay, give me your voodoo magic, whatever, I'll try it. And he said give it like he said like give it an hour or two and you should be okay. And it's been a couple, like I noticed later in the day it was a little better, and then the next day it was better, and now I feel normal. And I thought this is crazy.
Yeah, we will talk about it because I think I understand how that would work.
And he
Maybe.
gave me a YouTube video link. He said, so you can, now that you know what it is, you can watch this and you can do it to yourself.
Oh, really?
Yeah.
Will you email me that YouTube?
Mhm.
Okay.
Yeah. But it
Is
was
that
really
what-
interesting. I thought, what do I have to lose? Either it's going
It
to
is-
stay the same or it's going to get better. And it got better.
A what?
I'll have to go look.
My mom's gonna go look up what it is too.
He gave me some term for it, but I just was, yeah, it was a busy day at work and I just needed to feel better. So I didn't really
wow.
listen.
Wow. Okay. Well, and I can understand that. Yeah, that would cause that. I could see how that could cause vertigo. I think.
Well, and they look at your eyes. I guess your eyes do something. And he's like, yeah, you have it. The one side was worse than the other, but yeah,
Are
he's
your
like,
eyes ticking?
I don't know what he was looking at, but I don't know if they like try and focus, like
Okay.
contract or something. But when I when I was turning, he was staring down at my eyes. He's like, well, that side's not as bad. But when I did the other side, he said, that's really bad. And he did prepare me. He said, be careful, you may get nauseous.
Yeah.
Because of the turning and everything. And when I went, my right side was worse. So when I flipped to the right, I did feel really sick. Yeah, it was the strangest thing.
Huh.
Interesting. I said, see, you learn something new every day.
All right. Yeah. Yeah. Let's work to get there, and we'll talk about it. Yeah.
I'd love to see the video.
I just told her to email it.
Yeah, I'll email it to you when we're done.
It's an Epley maneuver.
Mhm.
It's called an Epley maneuver. It's EPLEY maneuver. All right, let's now that Becky helped me get off on a tangent, let's get back. Becky, I'm blaming it on you.
That's all right. I get blamed for a lot of things.
Okay, good. All right. So the dermatome are specific areas, specific patches of skin that are innervated by each given spinal nerve. So each of the spinal nerves innervates one specific patches of skin on the body. And that's defined as a dermatome, is which patches are innervated by which spinal nerve. We can map them using a dermatome map. Dermatomes can overlap by as much as 50%. But knowing which spinal segments are which spinal nerves, which segments are supplying each dermatome makes it possible to locate damaged spinal cord regions. One other way that not so much fun, but we can diagnose and determine what spinal nerve is located, innervated in what patch of skin or which dermatome. Let me put it this way. Which spinal nerves are responsible for what dermatomes? Is looking at shingles. So shingles is an acute infection of the peripheral nerves by the herpes zoster virus. So after one gets better from the chickenpox, you get the chickenpox when you're really young. It's caused by the varicella zoster virus. And then that virus remains dormant in the dorsal root ganglion. Do you remember what the dorsal root ganglia are? The dorsal root ganglia are the ones that are going to be right next to the dorsal horn of the spinal cord. And they contain the cell bodies of, the sensory neurons. And remember that the sensory neurons are the ones that are going out to specific receptors. So the virus remains dormant in those dorsal root ganglia, and we also call it the posterior root ganglia. In some people, it stays dormant forever, and it's kept in check by the immune system. However, if the immune system gets compromised, if the person gets stressed, the virus can travel along the sensory fibers via the fast axonal transport and cause shingles, which is a painful trail of skin discoloration and fluid-filled nerves along the dermatome. Yes? What? Very painful, my mother says.
My husband had it years ago and it's awful.
Really?
Yeah, he had it at like 26. He was young.
Wow.
Yeah. But yeah, it was still painful and he still has scars.
Oh, really?
Mm-hmm.
I didn't know that it scarred.
His did, but he's just an odd man.
It blisters the skin? Okay, it blisters the skin. So yeah, it could cause scarring.
Mm-hmm.
Oh. So last part of this chapter is we're talking about reflexes. Reflexes are the quick, involuntary, stereotyped reactions of glands and muscles. 4 basic things that define reflexes. They require stimulation. They require their responses to sensory input. They're quick. They involve few, if any, interneurons. Think about that for a moment. Where are the interneurons located? So the interneurons are found in the central nervous system, and they're kind of the middleman. So if most reflexes, they're the middleman in between the sensory neuron coming in and the motor neuron going back out. So if very few of them have interneurons, there's not going to be as many synapses either. We call this monosynaptic because what occurs is that the sensory neuron is going to synapse directly on the motor neuron, and there's not going to be an interneuron involved. And remember that all synapses, we have a delay. Well, if you eliminate the middleman, the interneuron, it goes from being 2 synapses to 1. That's why they're so quick. Or much quicker. Reflexes are involuntary. They occur without intent and are difficult to suppress. And they're stereotyped. They're going to occur essentially the same every time. So a reflex arc, and if you look at this relationship, you have a sensory neuron that's attached to a receptor. The receptor responds to a stimulus and sends a signal along the sensory neuron. The sensory neuron takes that signal back to the spinal cord, to the integrating center, which may include interneurons, it might not. And then we determine what our response is going to be, if any, and we send the message out via the efferent nerve fiber to an effector. Where have you seen this before? This relationship of a receptor, an incoming signal, the integration center, an outgoing signal, and an effector.
Not like a feedback loop.
Yeah, it is. So it's a feedback loop. It's a way that your body maintains homeostasis. One of the ways that your body maintains homeostasis is through, you can almost think of any feedback loop as being a reflex in a lot of ways. So the reflex arc includes those 5 components: a receptor, an afferent nerve fiber, an integrating center, an efferent nerve fiber, and an effector. Testing the somatic reflexes aids in the diagnosing of many diseases. Reflexes can be monosynaptic, they can be polysynaptic, they can be ipsilateral, and they can be contralateral. Monosynaptic meaning that the reflex arc skips the interneuron. So this is where the sensory neuron is synapsing directly on a motor neuron, and there's no interneuron involved. That's why we call it monosynaptic, because there's only one synapse. Polysynaptic is where we do include the interneuron. So there's 2 synapses versus 1. Ipsilateral are where the stimulus is occurring on one side of the body and the response is occurring on the same side of the body. Contralateral or when the stimulus is happening on one side of the body and the response is occurring on the opposite side of the body. So one example of an ipsilateral reflex is the stretch reflex or the patellar reflex. A muscle is stretched and it fights back and contracts. We use these a lot of times to help maintain equilibrium and posture. You tap on the patellar ligament and it excites nerve endings that are of muscle spindles. Muscle spindles are our receptor here in the quadriceps femoris. The afferent neuron is going to stimulate a motor neuron at that point. And we're going to have 2 different effects here. we're going to have the hamstring muscles that are below the quadriceps femoris are going to relax and get inhibited in their actions, while the quadriceps femoris is going to get activated. If you're going to have, if you have one set of muscles with contradicting activities against another set of muscles, one of those muscles has to be relaxed for the other one to contract. And that's what's
Mary, I get this done to me at the neurologist.
okay.
I just wanted to let you know, like I had this done already.
You had this done. I have hyperactive reflexes and I've always had them. And yeah, they tend to, they bounce back really quickly. Wendy, how quickly does it happen that you have a reflex?
That I don't know, but I get this checked because I have essential tremors, so they wouldn't want to see like my reflexes and how, you know, they're working, but I'm doing well.
Good.
But yeah, it's something I've done. I just thought I would share.
So one set of muscles is contracting while the other set is relaxing. That's an important part of reflexes, is that we have to have the complementary sets, one set being activated while the other set is inhibited, or things just aren't going to work. So flexor withdrawal or cross extensor reflexes demonstrate and also will demonstrate an intersegmental reflex arc, but specifically the flexor withdrawal, you step on a nail. We've all done this at some point, stepped on something. Another one, a good one, is to step on a Lego. Not comfortable. And when you do it, you trigger contraction of your flexors and relaxation of the extensors on the same limb. And in addition to that, to keep you from falling over, the extensors, so you trigger contraction of your flexors on one side and the relaxation of the extensors on one side. On the other side of the body, you contract your extensor muscles, which helps you maintain balance while you're extending the other leg. So, bear with me just for a second. So I'm walking along and I step on a needle. And the first thing that happens is I contract my hamstrings. In order to contract my hamstrings, I have to relax my quadriceps. That's the flexor withdrawal. One other thing that happens here that we'll see next is your abdominal muscles are going to contract for you to do this. But I'm getting ahead of myself. So you step on the nail, you pull your foot up, and to do that, you relax your quadriceps while at the same time contracting your hamstring muscles. Well, to keep you from falling over while you're relaxing these extensors, you're contracting these. That's the cross extensor part. So the flexor withdrawal is this. The cross extensor is where I'm contracting these muscles in order to keep myself from falling over. And in addition to that, you're going to have an intersegmental reflex because different parts of the spinal cord innervate the legs versus the abdominal muscles. And when you flex your hamstrings, you also are going to relax your abdominal, you're going to contract your abdominal muscles. If you like to work out, you will notice that when you're, a lot of times, if you're working out your legs, you're working out your abdominal muscles too. Questions? And this isn't really the best way to define this. I think I'm going to change this in the future, but which statement best describes reciprocal innervation or reciprocal inhibition? Which one best describes it? So contraction of an agonist with delayed relaxation of an antagonist. And when we talk about agonist versus an agonist is a muscle that allows you to do a certain action. An antagonist opposes that action. So a relaxation of an antagonist at the same time as contraction of an agonist. Simultaneous relaxation of the agonist and antagonist, or simultaneous contraction of the agonist and antagonist.
Or wait, no, sorry.
you-
Relaxation of contraction of.
Is it delayed? I think you're right. It's B because I don't think it's
Okay.
delayed.
Delayed. Oh yeah, no, I'm sorry, not delayed. Yes. The
Yeah.
relaxation, it's happening at the same time. The relaxation of the antagonist that
Right,
needs to pull back, like what you just demonstrated by standing up.
right,
The contraction.
right. Last part, Babinski reflex. This is where you you stimulate the sole of someone's foot by going up taking a probe, going up the medial side of their foot, and then over underneath the toes. Normally, if you get this done at this point in your life, it tickles. And the first thing you do is curl in your big toe. However, if you do it to a young baby, their toes will fan out instead of curling in. So if the sole of the foot is stimulated and the patient extends the big toe, it indicates that there's damage of the corticospinal tract. In babies, it's normal due to the lack of myelination. Up until they're about a year and a half, they'll show fanning out of their toes. So trauma to the spinal cord, a complete transection is complete severance of the spinal cord. It's the immediate loss of motor control below the level of injury. An injury above C4 poses a threat to respiratory failure. So paraplegia is a paralysis of both lower limbs. Quadriplegia is a paralysis of all four limbs. Hemiplegia is a paralysis of one side of the body. And paresis is a partial paralysis or weakness. Any questions about the spinal cord?
Does that also, excuse me, does that also apply like with strokes? They could have like paresis, partial paralyzed or weakness of limbs? Or is
Yes.
that considered something else?
Mom, can they have strokes in the spinal cord? Mom?
Or do they just have paresis because it affected something in their
Anywhere.
neurological issues?
But in your leg, they're called different things.
They're called different things.
Okay.
But
curious.
I think, honestly, I think it probably has more to do with a
The
stroke,
neuron.
meaning brain damage to the brain.
Okay.
Other questions that I can't answer? I wonder, I mean, I would think that it might get more easily fixed, but bleeding in the spinal cord would also do as much damage as bleeding in the brain. Because the meninges are doing the very much similar things, you know, the dura mater is the vessel supplies the blood vessels around the spinal cord. And it also is supplying a lot of the blood vessels around the brain. And I would think that the threat would be the same, maybe more pronounced in the cranium. But it would also, you're also, I would think you would see injury there too in the spinal cord, but I don't know how it all works. Why do I keep doing that? I don't know. Okay. Other questions about this chapter 13? Let's move on to chapter 14 here. Oh, Mary. Oh, this isn't what I meant to do. All right, where did I not put it on here?
You're done.
Oh, there it is. It's right there at the top. So the brain and the cranial nerves. you thought the spinal cord was fascinating. The brain is even more interesting because of all the organs of the body, this is the one we're probably, as a whole, most interested in. And at the same time, it's the one that we know the least about. So the brain is extremely complex. It is approximately 3 pounds of tissue that's used to simultaneously conduct and coordinate a variety of incredible processes with which no computer's ever been able to compete. And this is a typo here, but the brain's function is clinically associated with what it means to be alive or dead. All of the functions of the brain and many others are going to occur within 85 billion neurons, or 10 to 50 trillion neuroglia that comprise the human brain. What you all learn as we talk about this, we'll go through individual parts, but then when we start integrating them, you realize that one example of where the sum of all the processes and the value of the brain is well beyond the sum of all its parts. The parts are specific, but then when you start integrating them, then what you're talking about is far beyond the sum of all the parts. I don't know how clear that was, but I tried to say it. As a human embryo develops, the brain and brain stem are going to form from a neural tube that initially is going to form 3 anterior bulges. And these are the 3 primary brain vesicles. We're going to have a prosencephalon, a mesencephalon, and a rhombencephalon. Pro meaning before, mes meaning in the middle, and rhomb meaning behind. Just stop just for a quick moment here. So pro meaning before. Mes meaning middle. Rhomb meaning behind. What does encephalon mean? Encephaly means head. So what does encephaly mean? Encephaly is going to mean brain. If you've ever heard of a really nasty birth defect, anencephaly, what is that? What is that?
Is it swelling of the brain?
You're close. That's another thing that we'll talk about, what you're thinking about. I think you're thinking about hydrocephaly.
Yeah.
What's anencephaly? What does it mean when you put an A in front of a word or an AN in front of a word? like anaerobic.
Does it mean like lack of oxygen?
Yep. So anaerobic means a lack of oxygen. What do you think anencephaly is?
Brain dead?
You're
Ox- No oxygen to the brain.
you're really close.
Mm.
What about the absence of a brain?
Mm.
Oh,
That's what
Get
it is. That's why I'm saying it's a very nasty birth defect.
Mm.
that's
But it is. Go ahead.
Oh, how does that, is the child born like
so,
dead or?
Let me explain, and then I'm going to ask you later in the chapter to explain to me how this occurs. Okay. So anencephaly, it almost always they're babies that are carried to full term. If they're not aborted, they're carried to full term. They only live for a few hours after birth, typically, and then they die. And I had a good friend who had a little boy. We met probably about 7 years ago, maybe. And the second time that we spent time together, she said, "Mary, I don't think I've ever told you about my son." And I said, and I didn't even realize she had kids. So I was like, "No, I don't think you have." And he was born with microencephaly. And what that meant was that major portions of his brain were missing at birth. And he lived for 21 months and passed away right before he turned 2.
wow.
Anencephaly kids are almost always born alive. They're carried full term and they're born alive. They live for a few hours. Sometimes I've heard of one unique case where they live for a much longer period. But most often they die within the next few hours. Now, my question is, how are they live births at all? And so hold on to that question.
Miss Mary,
Yeah, go ahead, Casey.
have you ever heard of TY13?
Trisomy 13? Yes.
Like a few years ago, my niece was born with that. She lived for 5 days and she passed. But she had a lot of complications.
Yeah.
She was born with, I think, one kidney. She had a hole in her a hole in her heart. Her brain wasn't fully developed. But she went full term, like you said.
Uh-huh.
And during her mom's pregnancy, well, they did detect that she would possibly have that disease. It was like they told her it was a 1% chance she would come out with it, but she did come out with it.
Yeah.
And as soon as she came out, they had to basically put her in a reduced coma because she had a seizure and she continued to have seizures, excuse me, until basically her body gave out. It was sad.
It is sad. If you look at the chromosomes, and you know what, let's get off on a tangent really quick and we'll come back to this. But if you look at, we're talking about trisomy 13. If you look at trisomy 21, what is trisomy 21? There's a strategy to my madness here. But what is trisomy 21?
It has something to do with the chromosomes, right?
I was gonna say, I would assume
It
chromosome.
it does, and it's a defect that you're brought by far probably one of the most common and obvious defects that we see. What do you think it is? Someone Google it for me and tell me what it is.
Down syndrome.
is Down syndrome. So really quickly,
Sorry, I didn't mean to get off topic,
no,
but
it's okay because we don't talk about this. We don't talk about genetics for the most part. But here, and this isn't the best image. Let's see. That isn't a good image either. Let's pull this one out. So here's the first chromosome. You see, so this is a karyotype. So right before, when a cell is getting ready to divide, the chromosomes compact up. And they compact up into what we call metaphase chromosomes. And a lot of times, the way that they can assess someone's chromosomal composition or look for chromosomal abnormalities is to take a picture of what the cell looks like when it's actively dividing and line up all of the chromosomes. And based on the banding pattern, and this one isn't colored, let's see, here's a better one. Based on the banding pattern, you can see we've got black bands and colored bands. You can see that, right?
Mm-hmm.
Based on those banding patterns, you can pair them up. Here's chromosome 1, here's chromosome 2, here's chromosome 3, 4, 5, 6, 7, 8, all the way to down here. This is a trisomy 21. The way I can tell that is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. You notice that all of the others have two chromosomes. You get one from your father, you get one from your mother. Trisomy 21 is where rather than having just one from your mother and one from your father, you get two from one of them. Trisomy 13 is the same, works the same way. But it's happening. It's happening with this one instead. Now, like Casey said, that baby needed special care right from, was it a boy or a girl, Casey?
a girl.
Yeah, I think all lives matter, so I like to put identities with them. Like that little, as soon as that little girl was born, she required very special care. And regardless of that special care, she died within 5 days.
Mm-hmm.
What makes this is a trisomy 13, much more lethal than this, which we see all the time. What is the difference in the shape and structure of this chromosome, and this chromosome? Now, don't think too hard about this. Look at their overall size. Which one's bigger?
One.
The one is much bigger. A trisomy 1 will never survive. The smaller the number of the chromosome, like chromosome 1, the more vital it is for life. And the more anomalies there are, as my mom just said. There's more genetic material on this chromosome than on this chromosome. Trisomy 13, like Casey said, I don't think I've ever heard of one that lasted, the baby survived for very long. Because it's a chromosome. What? Oh, we had a neighbor who had trisomy 13 who survived for 4 months when I was younger.
Wow.
Casey, one of my students here, had a niece who survived for 5 days. So the thing is that the gene dosage is evolutionarily conserved for life. You are exactly 2 of each. If you have more or less than that, we do have monosomies out there. Mono meaning that rather than having 3 chromosomes or 2 chromosomes, you have 1. They're just as difficult to live with as trisomies are, because it's evolutionarily conserved that you will only have 1 dose of each chromosome, or 2 doses. Let me put it this way. It's evolutionarily conserved that you will only have 2 doses of each chromosome. If you have more than that, what you're doing is you're producing an extra set of proteins. If you think of it that way, you're producing an extra set of proteins that don't have complementary proteins. We need them evenly matched, and it's evolutionarily supposed to be like that. And when there's more or less than that, depending on which chromosome is involved, it's much more likely to impact life and vitality. I think the other one that I know of is a trisomy 8. So it's this one. And they don't survive for more than a little while. All of the others are embryonic lethalities, meaning they die before they're carried to full term. Casey, I'm sorry your sister had to go through something like that, or your brother.
Yeah, thank you. It was my brother.
That's a painful deal. I can't even imagine.
Yeah, it was.
Yeah, I'm so sorry.
Yeah, that's tough. I'm sorry, Casey.
Well, thank you, Becky.
I really enjoy children. I've never had a child of my own, but I love children.
I have 2. You want them? Mine are children. They're 16 and 19. They're mini adults. So
I want to be married before I have them. I'm waiting on that one. But I think for me, the idea of having a child and losing them is much worse than having a child, not having a child at all. Does that make sense?
Mhm.
I think that would be much harder for me than where I'm at right now, where I just don't have any. I
right.
can't imagine having one just to lose them.
Yeah, that would be very tough.
But all right, now we're gonna quit going off on tangents just for a little bit. And no, we don't talk about genetic, but all of what we're talking about in physiology is based on genetics. So thank you, Casey, for bringing that up.
No problem. Thank you for explaining everything to us.
You're welcome.
Mhm.
So brain development. The forebrain is the prosencephalon, the midbrain is the mesencephalon, and the hindbrain is the rhombencephalon. Keep these in mind. So these are the first 3 brain vesicles. The next thing that occurs is an encephalization, which means that the prosencephalon, that first vesicle, and the third vesicle are going to further divide so that we're going to form 5 secondary brain vesicles. And the telencephalon, no, wait, I'm jumping ahead. So prosencephalon and rhombencephalon are going to further divide so that ultimately we go from having 3 vesicles to having 5 vesicles. This figure is not in your book. but I really like it. I made it because I like, it maps out what vesicles are going to form what structures. So here's the first three vesicles: the prosencephalon, the mesencephalon, and the rhombencephalon. The prosencephalon during encephalization is going to form the telencephalon and the diencephalon. The mesencephalon is going to stay the same and continue as a mesencephalon to form these structures. The rhombencephalon is going to divide to form the metanocephalon and the myelencephalon. From the telencephalon, the cerebral hemispheres are going to form. From the diencephalon, the thalamus, the hypothalamus, and the epithalamus are going to form. The mesencephalon is going to form what's called the corpora quadrumina, the cerebral peduncles, cerebral aqueduct, and the substantia nigra. The metanocephalon is going to form the pons, which is part of the brainstem, and the cerebellum. The myelencephalon is going to form the medulla oblongata, which is part of the brainstem. Do me a favor and make flashcards of some of these, because these are really good questions, and it really is a lot of memorization. This specific little part is memorization. We're going to talk about the functions of each of these as we move forward here. During the first 2 to 3 months of the developing embryo, there's an expansive growth of the telencephalon. Remember, the telencephalon is going to form the cerebral hemispheres. So there's a massive expansion of the telencephalon, which is going to cause the outer portion, the cortex. Every time we talk about a cortex, we're referring to the outer portion of the cerebrum to extend over and around much of the underneath inner brain. And so the brain at this point, with the telencephalon developing so fast and forming the, and essentially encompassing the center, is growing at this amazing rate where approximately 50,000 neurons are being added each second. And at birth, almost all the neurons of the brain that are present that you will ever have. So the telencephalon is what's going to develop into the cerebral cortex, which is going to be a big deal here in a little while. So like the spinal cord, we have gray matter and we have white matter. The gray matter, just like the spinal cord, has a dull color due to the very little myelin. It forms the surface layer, the cortex, over the cerebrum and the cerebellum. Just like the gray matter in the spinal cord, it's composed of neurosomas. Remember, those are cell bodies. Soma meaning cell body. The dendrites and the synapses. The gray matter is also going to form nuclei deep within the brain. Remember that we use nuclei is different than the internal part of a cell, which is what we think of a nucleus of a cell. A nuclei is an organization of specialized cell bodies when we talk about the spinal cord and the central nervous system. When we think of cell bodies out in the peripheral nervous system, we're referring to ganglia. When we talk about them in the central nervous system, we're referring to nuclei. White matter is deep to the gray cortical matter. And remember, when we were looking at cross sections of the spinal cord, it's the opposite. In the spinal cord, the gray matter is deep to the white matter. In this case, the gray matter is the white matter is deep to the gray matter. So it's the opposite. And just like the white matter and the spinal cord, it looks pearly white because of the lipid. Remember, it's myelin. Or excuse me, remember that the myelin is lipid. Getting my words all confused. Remember that the myelin is lipid. And it's composed of tracts. What are tracts? Talked about the corticospinal tract, talked about the spinal thalamic tract. What are tracts?
Bundles of axons?
Yeah, they're myelinated bundles of axons. So this is the way that one part of the cerebral cortex is going to communicate with another part of the cerebral cortex, is via these tracts, these roads. Some major landmarks: the cerebrum, 83% of the brain volume. Cerebellum is called the little brain. The cerebrum is the big brain. The cerebellum is the little brain. Here's the cerebellum. Here's the cerebrum. Cerebellum contains about 50% of the neurons and is the second largest brain region. The diencephalon, remember this was one of those first vesicles. The diencephalon is going to consist of the epithalamus, which has the pineal gland, the thalamus, and the hypothalamus. Here's the hypothalamus. Here's the pituitary gland. Do you remember talking about the sella turcica when you were talking about the bones in lab? Maybe.
No. I was like, I don't, but.
So in the bottom of the cranium, in the cranial base, you remove the brain and you're looking, and you've sawed off the top of the skull and you're looking down at it. There's a little tiny indentation, and we call it the sella turcica, which is a Turkish saddle. That's
Okay.
what
Yep.
it means. You
Yep.
talked about it? Okay.
Yeah. When you said Turkish saddle, I was like, yeah, we did.
Well, you did. Okay. Well, the pituitary gland sits in there. Sits in that little saddle area. So here's the hypothalamus. Here's the pituitary gland. Here's about where the sella turcica would be. Here's the thalamus. Here's the epithalamus. And here's the pineal gland. The brainstem is the midbrain, right here, the pons, and the medulla oblongata. If the telencephalon was removed from a 5-week embryo, which of the following structures would fail to develop in the fetus?
A.
You're right. the cerebral hemispheres. Where does the thalamus form from? It forms from the diencephalon. The midbrain and the medulla oblongata are going to form from the rhombencephalon, from the metencephalon and the mesencephalon. So the brain, if you remember, we're talking about the spinal cord. Why are spinal cord injuries so tragic and so scary?
Because they don't regrow.
They don't regrow. The brain is the same way. So we have, just like we have it around the spinal cord, we've got bones that protect the brain, and we've got meninges that protect the brain. Just like in the spinal cord, remember that the meninges are continuous with the brain and the spinal cord. So the dura mater is this very tough outer covering. Has Dr. Weeks, has he had a chance to do a brain dissection with you? Was he able to do that?
No.
All right, next week, I ordered one. I ordered a fixed brain, and I ordered it from, there's a company in North Carolina that you can order fixed sheep brains from. And I have one coming in the mail, and I'm going to dissect it in my lab, and I'll try to bring some pieces with me next time. I'll bring some, I'll show you some pieces next time. But the dura mater is this very tough outer covering. The arachnoid mater is a spidery layer. We talked about arachnophobia. It's the same thing. It looks just like a spider web. And then the pia mater, you're looking through it when you're looking at the surface of the brain. Apart from protection, they provide a structural framework for arteries and veins that service the brain. There's a few exceptions, a few differences in these meninges. In the brain, the dura mater is composed of 2 layers. There's an outer periosteal layer and an inner meningeal layer. So periosteal, remember that's the inner surface of the bones, the periosteum. So this is the layer, the outer periosteal layer is going to be right adjacent to the cranial bone. The inner meningeal layer is going to continue down to the spinal cord, forming the dura mater of the spinal cord. These 2 layers are separated by dural sinuses. And these are going to be really important when we talk about the circulation of the cerebrospinal fluid here. But these dural sinuses, you can see a little bit, here's the indentation right there. These dural sinuses are where blood is collecting, that's circulating through the brain. What do you not see here? You don't see an epidural space. We don't have a subdural space either. However, people die of subdural bleeds. One of my ultimate favorite authors, I love to read. And one of my ultimate favorite authors was Robert Ludlum. Are you familiar with anybody familiar with him? I'm showing my age here, but are you familiar with him?
Mm,
No.
I didn't think so, but it was worth a shot. You're probably more familiar with one of his books, The Born Identity.
mm,
Yeah, I know that.
Everybody knows that book.
right.
So that was probably the second series that he wrote. And he died right before that movie was to open in theaters. And what he died of was a subdural bleed. What does that mean? If an epidural is a shot into the epidural space, what's a subdural bleed? Epidural meaning an injection into the space above the dura mater. What's a subdural bleed?
Is it like a bleeding in the brain?
Where in the brain?
Outer
Think-
side?
Well, think of let me think of what I'm saying. It's a subdural bleed. Where is it occurring? Where's the subarachnoid space?
It's underneath like the within like the dural sinus.
It's underneath. What is it? There's 3 layers. What is it underneath, Cat?
The dura mater.
No, well, the subdural is, where's the subarachnoid space?
Subdural
not-
space.
Where's the subarachnoid space? We
So
talked about the-
underneath, it's underneath the arachnoid matter, like in between the brain and
Yep.
and that layer.
It's in between
And then-
the arachnoid mater and the pia mater. So where would a subdural bleed occur?
From the
Blood vessels?
Well, where? You're right, from the blood vessels, but where is it going to bleed? When we
subarachnoid space.
All right, wait, let me, I'm gonna type.
Oh, into like onto the gray matter.
Let me stop just for a second, because I
Bleh.
think, let me type this out for you. So subarachnoid space is underneath the arachnoid mater, right?
Yes.
A subdural space is where? Where's subdural? Where would that be?
Under the dura mater.
It's underneath the dura mater. So a subdural bleeding is going to be bleeding in underneath the dura mater, right?
Mm-hmm.
How does that happen? Usually it happens from a good conk on the head.
That's what I was gonna say, like a concussion, a bang.
Yeah. I mean, have you ever, the one really scary thing with little tiny kids is you sit them on a stool and they go back and they smack their head on a rock tile.
Yep.
And what's the first thing that they start to do? They start to cry, and then they will often get tired.
Yep.
That's scary, because that can be a sign of a bleeding or a concussion. And I remember one of my, growing up, my sister had a friend who had a child in her teens. And the little boy was sitting on something and went back and smacked his head. And I remember his mom bringing him over to my mom and asking her to check him and make sure he was okay, because he'd started crying and then gotten tired. and he was fine. But that's how another person. So this author, Robert Ludlum, died of a subdural bleed. I'm guessing he went back and smacked his head. Another one is Gary Coleman. Are you familiar with that actor?
It sounds familiar.
Wasn't he the little guy from
Derek, yeah.
From where?
the TV show with the rich white family is
Different Strokes.
there
Yeah.
you go.
I was like, so you're showing your age too, what you're saying is that, all right, that's funny.
Yeah.
But Gary Coleman died of an epidural bleed. Where would that be?
And his spine.
No, an epidural bleed.
Oh,
You're right, it could be in the spine, but it wasn't in the spine. We don't have a subdural space
right.
in the brain, but the bleeding will create a space. Normally you wouldn't have a space there, but the bleeding creates it. Where would an epidural bleed occur? You guys don't think too hard about this. Where if a sub is below, what's an epi?
Above.
Above. So a bleeding that's going to occur top of the
Above.
dura mater, right?
Yeah, on top of the
Yeah.
brain.
That's
skull.
that's how he died.
Mm.
And just reading the story again the other day, he slipped and fell in his kitchen.
Wow.
So one of the things that makes the meninges fascinating, and another fun thing about learning about physiology and anatomy, is that when you hear this kind of stuff about people with bleeding, you can tell where that bleeding occurred. So the layers are separated by these two layers of the dura mater are separated by the dural sinuses. The dura mater is also with these two layers is going to form some folds and some fissures. The false cerebri is going to extend into the longitudinal fissure.
We're still on your white screen. Just
Oh
just so you
shoot,
know.
darn it. Here, thank you for saying something. The false cerebri is going to extend into the longitudinal fissure right here. So it's this right here. The tentorium cerebelli is going to separate the cerebellum from the cerebrum. So it's this, I think of the tentorium as being a tent that's going to cover the cerebellum and separate it from the cerebrum up here. The false cerebelli is going to separate the halves of the cerebellum. So the false cerebri is going to separate the two hemispheres. The tentorium cerebelli is going to separate the cerebellum from the cerebrum. It's going to be here, the cerebellum would be down here. And the false cerebelli is going to separate the two halves of the cerebellum. In these folds are where we find these dural sinuses, where the blood is going to collect that's circulating. Meningitis is inflammation of the meninges. Can be caused by a bacterial or viral invasion of the central nervous system by way of the nose and the throat. I have a student this semester in one of my classes who said that she got meningitis from a salmonella infection, which is a parasite. So obviously it can occur from other things besides bacteria and viral. The pia mater and the arachnoid mater are those that are most affected. It can cause swelling of the brain, enlargement of the ventricles within the brain, and hemorrhaging. So blood supply to the brain. We talked about those dural sinuses. Blood supply to the brain. The brain represents about 2% of the total body weight, but receives about 20% of the body's blood supply. It consumes about 20% of the oxygen and glucose, even when resting, of the body. The internal carotid arteries supply the blood to the anterior portion of the brain. The vertebral arteries, do you remember when you were looking at the bones, in the vertebrae of the cervical vertebrae, there's an extra hole that's present there that's not present in the other vertebrae. Do you remember that? When you look at the cervical vertebrae, there's a little hole. Let me just draw one really quick here. Here's a cervical vertebrae. I'm not doing a very good job drawing this. Let's try this. That's a terrible drawing, but here's the body. Here's the spinous process, and they're bifurcated for the cervical vertebrae. And right off to the side, on both sides, right next to the transverse processes, are these little holes. And we call them the transverse foramina. They are where the vertebral arteries are going to come up from the aorta to the brain. I know that's a really crappy drawing of a cervical vertebrae, but you got to put up with whiteboard on Zoom. So here's the transverse processes. Here's the spinous process. Here's the body. Here's the transverse foramina. Make a connection here. So the internal carotid arteries are going to supply blood to the anterior portion of the brain, right here. And the vertebral arteries are going to supply blood to the posterior portion of the brain. Within the base of the brain, we have this circle, this ring of arteries that's called the circle of Willis. It's always been easy for me to remember because I have some Willises in my family, and I also have a good friend named Willis. So this is a circle of Willis. It's a ring of arteries that's formed from anastomoses at the base of the brain. Anastomoses are a coming together of vessels, conjoining of vessels into a plexus of vessels. So this is a ring of vessels that's formed between the internal carotid artery and the basilar artery. To put this in context, here's the vertebral arteries. Well, they're right here and right here, that are going to merge to form this basilar artery. And the basilar artery is then going to join into this ring. Here's the posterior cerebral arteries. And up about right here, we're going to have the internal carotid arteries. Here's the middle cerebral arteries. Here's the anterior cerebral arteries. So looking at this circle, here's the vertebral arteries. Here's the basilar artery. Here's the posterior cerebral arteries. This is the front of the brain, anterior surface. This is the posterior. So vertebral arteries, basilar arteries, posterior cerebral arteries, the middle cerebral arteries, and the anterior cerebral arteries. Why do we want a circle here? Why would that be a good idea?
I would say because it flows better, the blood flows better.
Why do you think it flows better? Why doesn't it matter if it's a line or a circle?
Does it, like, it just is quicker, like it, I would think it would move faster.
It might move faster, but another thing is, what if you get a clot right here? If this was not a circle, if there was a clot right here and it's just extended out like this, everything that was supplied with blood from this vessel right here would die. But when there's a clot there, and because this is a circle, the blood can flow another direction. That's why this circle is so awesome, is because it's going to lower the risk of occlusive strokes, which is what we're going to talk about next here. So we have hemorrhagic strokes. People like to say someone dies of an aneurysm. That isn't the case. You don't die from aneurysms. You die when those aneurysms, which are weakened blood vessels, burst and hemorrhage. That's when you die from an aneurysm. So a hemorrhagic stroke is when a blood vessel bursts and bleeds into the brain. An ischemic or occlusive stroke is when blood flow is blocked by a blood clot. Both are equally as bad. Because blood is a great thing, but it's also a bad thing when it's toxic to some cells. We'll talk about the fact that we have a blood-brain barrier that's very vital for maintaining the health of the brain, because it keeps the red blood cells away from certain tissues. So both of them are bad, and it just matters where they occur, but they're both going to cause a lot of damage. Dural sinuses receive the circulating blood and empty into the interjugular veins. Where were the dural sinuses? What were they again? Those were the sinuses that were formed by the two layers of the dural mater.
Mm-hmm.
So the dural sinuses are gonna, I'm gonna keep going today, just be patient with me here. The dural sinuses are gonna receive the circulating blood and empty into the internal jugular veins. So if you remember, we showed that cross section. I'm sorry, I'm gonna skip. What number is this? Okay, I'm gonna go back up. Right here, this little, right here, this little indentation, here's the periosteal layer of the dura mater. Here's the meningeal layer of the dura mater. With that in mind, that's this right here. So this is called the superior sagittal sinus. Sagittal, what's a sagittal section? Sagittal section is going right through the middle. So think of the superior sagittal section as going right through the two hemispheres. Here's the false cerebri. Here's an inferior sagittal sinus. In the back, right around where the tentorium cerebelli is, we have a transverse sinus. The blood and the circulating cerebrospinal fluid is reabsorbed here. And it empties back into the heart via the jugular veins. Mom,
Yeah.
can you come and take her out?
Yep.
Sorry, our little dog is not really well house trained, but when she sits on my lap, she's not going to do anything on my lap. And when she's on my lap and she starts to get active, I know she probably needs to go out. We're working with her to get her there. The vascular endothelium around the brain capillaries forms the tight junctions with the perivascular feet of the astrocytes. What are the astrocytes? Do you remember that word from chapter 12? A long time ago. Astrocytes are neuroglia, and they're the ones with the most amount of functions. So one of the functions of the astrocytes is to be involved in the formation of the blood-brain barrier. And so they put out these little perivascular feeds. Think perivascular meaning around the vessels. Put out these little processes of feet. And then those little processes form tight junctions, ensuring that anything leaving the blood must pass through the cells and not between them. This allows for the passage of essential metabolites, but prevents the passage of larger materials into the cerebrospinal fluid.
Covered in warm.
So the blood-brain barrier can be an obstacle for delivering medications like antibiotics and cancer drugs that we use by introducing them into the bloodstream. Trauma and inflammation can damage the blood-brain barrier and allow pathogens to enter the brain tissue. There are certain areas of the brain that are not covered, that don't have the blood-brain barrier. These are the circumventricular organs, which are in the third and fourth ventricles, which we'll talk about here in a second. This is where the blood can have direct access to the brain. And it enables the brain to monitor and respond to fluctuations in the blood glucose, the pH, the osmolarity, and other variables. The circumventricular organs also afford an easy route for the invasion of the human immunodeficiency virus or HIV. Did she go? I knew she would. So why is the blood-brain barrier ineffective against alcohol? And I'm sorry, that's a typo. It's obviously written there twice. I'm not honestly sure what the answer is here. I did not come up with this question. But
Well,
go ahead.
So
ahead.
like, you think it's not C because like, wouldn't you think it can go to the brain? I'm just trying to do elimination.
It can affect the cerebellum,
Right.
which is part of the brain. And it can affect it is able to affect the brain.
Right. Well, that's what I meant. I'm sorry. I'm talking to
You're
my,
okay. Don't worry about it.
but no, I was thinking, because like if you're intoxicated and it goes the alcohol, that's how they do like the alcohol levels, right? They check your blood alcohol level, which
Right.
Goes into your system right away.
Right.
So I don't know. I mean, what is it like?
I think it's either the blood-brain barrier prevents only blood cells from reaching the brain, or alcohol is semi-lipid soluble. Looking at the structure of methanol, which is the typical alcohol that you find in all alcoholic beverages, it is semi, but very small lipid soluble. But I'm thinking that it's alcohol is water soluble. And and water can pass through that tight junction. So I think that's the answer, but I'm not positive about it. I really
So
should
that
take
question will not be on our test.
no, and I mean it's really, I should take it out if I can't answer it. But I think it's a good question anyway, because we know that alcohol affects the brain.
Yeah.
Which of the following is not a true statement regarding the blood-brain barrier?
Who knows? It's C.
No, because it does often prevent the passage of possible therapeutic drugs, like chemotherapy drugs are often gliomas, brain tumors are often resistant to chemotherapy because of the blood-brain barrier.
Okay.
I was going to say B.
Why is it B?
Well, looking at the diagrams and our discussions, I did not hear much about a gap junction.
Yeah, we don't have gap junctions. Gap junctions would be tunnels in between the cells.
Right.
We don't have that. We have tight junctions, but we don't have gap junctions. So ventricles are cavities within the brain. The brain has the consistency of cold cooked oatmeal.
Ugh. It's a weird analogy. That I was like, ugh.
The ventricles are filled with cerebrospinal fluid, and they keep the brain from collapsing on one another. If you think that, if you've ever looked at cold cooked oatmeal, how well does it hold its shape?
Well,
It-
It will.
I was gonna
well,
say it
yeah,
will. It depends on how
reasonable-
you like your oatmeal, but yeah,
reasonably it will hold it,
yeah.
but eventually it's gonna fall in on itself, right?
Mhm.
Or it's gonna fall off. It's gonna blah. These ventricles in it are filled with cerebral spinal fluid within the brain, and they prevent the brain from collapsing in on itself. So here's the ventricles. We have two lateral ventricles, one here, right here, 1, 2. Then we have a third ventricle right here. We have a fourth ventricle right here. So here we have 2 lateral ventricles. We have a third ventricle right here, and we have a fourth ventricle down here. So the cerebral spinal fluid is going to circulate through the ventricular system. The fourth ventricle, from the fourth ventricle, it's going to flow into the central canal. Where's the central canal? Where have you heard that term before?
It runs up through the spinal cord,
Yeah,
the base of the brain. Or the,
yes,
yeah.
yes. So from the fourth ventricle, the cerebral spinal fluid is going to flow into the central canal. So the cerebral spinal fluid is this clear fluid that's going to continually circulate through the ventricles of the brain and spinal cord, and it's going to bathe the brain with oxygen, nutrients, and other vital chemicals. Basic mechanical functions of the cerebral spinal fluid. It provides buoyancy. The brain is going to float within the cerebral spinal fluid. And the brain is going to be, and remember, the brain is about 3 pounds, right? It's going to float with this on this cerebral spinal fluid. And through its ability to float in the cerebral spinal fluid, it's going to be prevented from crushing under its own weight. Without the cerebral spinal fluid to support it, portions of the brain would sink through the foramen magnum. It also protects the brain. Through the cerebral spinal fluid provides a liquid cushion that protects the delicate neural structures from sudden movements. Some homeostatic functions. It transports nutrients and chemical messengers to the brain and removes waste products from the brain. It protects the nervous tissue from chemical fluctuations that would disrupt neuronal function. And waste products and excess CSF are eventually going to be transported into the venous circulation via those superior sagittal sinus and inferior sagittal sinus and the cavernosus sinus and so forth. Well, how does it circulate? It's produced by the choroid plexus, which is made from blood plasma that leaks out of tiny specialized vesicles called the choroid plexus. And then it gets passed through ependymal cells. Ependymal cells, where have you heard ependymal cells before? What are those?
Mm.
I don't know. Is it the skin? Like,
No, those are.
No.
The epidermal, yep, we go,
no.
sit close, close.
Oh, I can't think.
What about, I know it's an early morning, I can tell you that. What about the neuroglia, the epidermal cells?
Yeah, that was in.
From chapter 12, the epidermal cells, that's a function of those neuroglia, the epidermal cells, is to secrete cerebrospinal fluid. So these epidermal cells make up the choroid plexus, which is then going to secrete cerebrospinal fluid into the ventricles. One thing that we'll see when we get the sheep brains is that if the inner ventricles look black. Because what does clotted blood look like? It looks black.
Mm-hmm.
And so when I had in my anatomy class that I teach for Stevenson University, we were dissecting sheep brains a couple of weeks ago, and one student was like, "What's this black stuff?" And I'm like, I don't know. And so I did some research into it, and it was in the ventricles. What we were looking at was the third ventricle. We were looking at the choroid plexus, the black stuff. So the ependymal cells look like simple cuboidal epithelium that is ciliated, but it doesn't have a basement membrane. And the cilia keep the cerebrospinal fluid flowing in one direction. It flows under its own pressure gradient and the rhythmic pulsations of the brain due to the heartbeat. It's returned to the blood via the reabsorption through the arachnoid villi that are located in the dural sinuses. For example, the superior sagittal sinus. So it's secreted in the lateral ventricles, moves through what's called the interventricular foramen into the third ventricle. Then it moves from the third ventricle into the cerebral aqueduct, from the cerebral aqueduct into the fourth ventricle. And then it flows through these little apertures into the subarachnoid space. And then it's reabsorbed by the arachnoid villi in the superior sagittal sinus. Now, with this in mind, here's a picture diagram. So here's the lateral ventricles. So the cerebral spinal fluid is secreted in the lateral ventricles. It moves in via this interventricular foramen into the third ventricle, where the cerebral spinal fluid continues to be secreted. It flows down the cerebral aqueduct into the fourth ventricle. And then it flows down the central canal in the spinal cord. And it flows around into the subarachnoid space on the central canal. And it bathes the external surfaces of the brain and the spinal cord. So it bathes, circulates, moves up, moves up, moves up. And it gets reabsorbed into the superior sagittal sinus through these arachnoid villi that poke up into the superior sagittal sinus. So here's the subarachnoid space right here. is right here. All the way up. And then it gets reabsorbed from the arachnoid villi into the bloodstream again. So it comes from the blood, it gets reabsorbed back into the blood. Questions? Hydrocephalus, someone mentioned this initially. What is it? What does hydro mean?
Water.
What does cephalus mean?
Brain, right.
What? It means head or brain.
Yeah.
So hydrocephalus is water on the brain.
Mm.
So it's an abnormal accumulation of the cerebrospinal fluid, usually resulting from a blockage in the flow or route of the CSF and its reabsorption. In a baby whose fontanelles have not yet closed, remember those are the parts of the cranial plates that aren't sealed. The head bulges due to the increased pressure. Questions? So the brainstem, you guys, let's take 5 minutes. I said we were going to just continue, but I'm realizing I'm getting a little brain dead here. I can only sit in front of my computer for so long sometimes.
All right.
And it's worse when I'm tired and it's an early morning.
And
So
it's an ugly day.
Yeah.
It is kind of a yucky
Very.
day.
But
Let-
I don't think it is that as much as brain dead, Mary.
I feel kind of brain dead though. Let's take 5 minutes. So we'll come back at 10:34.
Right.
Let's take 5 minutes here.
Thank you.
You're welcome. I can go through a little bit over. She tolerates it. I'm still going to do it again because I turned it on. Turned it on. Oh.
It is cold in there.
Oh, it is turned on, Mom.
No, it's not.
It says it is.
64, isn't it? No, it said it's 65. 70 degrees. You must have pushed because it was set at 64, that's why I set it.
I did.
That's not all.
You
It's already.
only just bump it up 1 degree at a time.
That's when you're already out. It's not running at all. You have to set temperature. where you want it. Nice. You have such a.
Too early in the morning. Lucky Ruby can wipe this out.
Yes. Oh, I know that one or the other of us gets too big.
We would have slept through it if I didn't.
Oh, my goodness, I can't. What? Oh,
I probably have to, yeah. This, she was working so well, that she's scared.
Biol.
Gotta go to the sheriff.
No, Dave's here. David's here. He wants to see. Going up in my time to get
Or I asked him what they had. I know she
They,
didn't
they,
labor.
they got a little boy, 6 pounds, 2 ounces this morning, 6'5".
Okay.
David Luke.
Okay, so let's come back here. So the brain stem is continuous with the spinal cord, and it's divided into 3 parts. The midbrain, the pons, and the medulla oblongata. Just to put this in context, looking at this picture here, if you continue more inferior here, continue in a more inferior direction or more caudal direction, this is where the spinal cord would be. Right here is where the thalamus would be. Here would be where the lateral ventricles would be. And this area right here would be the cerebral hemispheres. So brainstem, three parts: the midbrain, the pons, and the medulla oblongata. Looking back at that original diagram that was at the very beginning of this chapter, which brain vesicle does the medulla oblongata develop from? Somebody go back and look. Somebody go back and look and tell me. Somebody there?
Is it A?
I think you're right. The myelencephalon?
Yes.
You're right. Good job, London. So moving back down again. The medulla oblongata is has a pair is consists of a pair of pyramids. So it's a pair of ridges. Looking here, here's the pyramids right here, right here, right here. That assemble two side-by-side baseball bats. Off the medulla oblongata, there are four pairs of cranial nerves. What distinguishes the cranial nerves from the spinal nerves? Before we continue forward here, we'll talk more about the cranial nerves at the end of this chapter. But what makes the cranial nerves different from the spinal nerves? The cranial nerves are going to come directly off the brainstem. The spinal nerves come off the spinal cord. The cranial nerves are going to come directly off the brainstem. So four pairs of the cranial nerves are going to come off the medulla oblongata. And we use Roman numerals when we talk about the cranial nerves. We're going to cranial nerve number 8, 9, 10, and 12 are going to begin or end in the medulla. The pyramids contain the descending fibers of the corticospinal tract. So remember, we talked about the corticospinal tract, how it carries the motor signals out to the skeletal muscles. The pyramids contain those tracts. Also, all of the ascending and descending fibers connecting the brain and spinal cord pass through the medulla oblongata. So kind of a big deal. If you think about it, all of the tracts are going to pass here. One thing that we have in the pyramids is we have a decussation of the pyramids. What does it mean to decussate? You remember that term from last week? Decussate meaning that things are going to cross over. So the axons from the left pyramid are going to cross over to the right, and the axons from the right pyramid are going to cross over to the left. So as a result, the left hemisphere of the brain is going to control the voluntary movement on the right side of the body. Remember, this is the corticospinal tract. The axons from the left pyramid are going to cross over to the right, and the axons from the right are going to cross over to the left. So the left hemisphere of the body is going to control the voluntary movement of the right side of the body, and the right hemisphere is going to control the voluntary movement of the left side of the body. One other thing is the medulla oblongata is going to contain the nuclei that house the respiratory centers and the cardiovascular centers. The cardiovascular center controls the rate and force of the heartbeat, the diameter of the blood vessels. The medullary rhythmicity center controls the rate and rhythm of breathing. And the medulla oblongata is going to house the centers that regulate vomiting, coughing, hiccuping, deglutition, which is swallowing, and sneezing. It's also going to contain other nuclei that we're not going to discuss. Remember what nuclei are again. These are centers of cell bodies. The pons, the pons means a bridge that connects the spinal cord with the brain. Pons means a bridge. Here it is right here. Here's the medulla oblongata. Here's the pons. Here's the midbrain. That it's the anterior bulge in the brainstem that's rostral to the medulla, and it's going to develop from the metencephalon. Pons means a bridge that connects the spinal cord with the brain. It consists of nuclei and tracts. Remember that nuclei are cell bodies, tracts are myelinated axons bundles. The pons is going to relay nerve impulses related to voluntary skeletal movements, so like the corticospinal tract, coordination of the cerebral cortex with the cerebellum, contains the pneumotaxic center, which controls the breathing rate, and the cranial nerves that are 5, 6, 7, and 8. Now I'm going to go off on one more tangent today, and just be patient with me here. Have you ever heard of someone dying from an opioid overdose?
Yes.
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 Almost all of us have. The reason they die of an opioid overdose is because it acts on these pneumotaxic centers. It acts on the medulla oblongata, it acts on the pons. So if you think about it, if opioids are causing death, they're causing death through altering the rate of the heartbeat, altering the rate of the breathing. Now, let me tell you a little bit about another personal story. So I've shown you my panoramic of my dental panoramic where I broke my jaw. When I broke my jaw, two things happened during that time, in addition to breaking my jaw. I was in the hospital for 10 days. And I had surgery probably after about 24 hours after I was admitted. I had surgery to fix the jaw. And then I stopped breathing in the recovery room. And so they had to remove all the wires that they'd used to wire my jaw shut and bag me and allow me to start breathing again, because all the swelling had just sealed off my trachea. And then about 4 days into this adventure, I had a morphine-induced respiration suppression. What that means is essentially a morphine overdose.
Wow.
And I remember it fairly well. I remember I was, I'd broken my jaw, and like we talked about before, it was kind of a big deal because I'm not a very big person. You can't see my picture. I don't know why you're not seeing my picture. Because I am here. I'm just not here in the picture. But my jaw isn't very big, and breaking it in 4 places was a lot. And so I was very swollen. And the fact that I'd stopped breathing in the recovery room meant that I was being very carefully monitored. And I suffered a really nasty case of whiplash, so I was pretty immobile all at the same time. And so I was laying there in ICU. And in ICU, when you're in ICU, you get a lot more one-on-one attention than you do on the other floors. And so there was a nurse in my room, and all of a sudden I got a really, really, really nasty headache. And I remember it came on really, really fast. And I must have already been semi-hypoxic. I must have been bordering on being hypoxic, because I was wearing an oxygen mask at the time also. But I could talk. I wasn't on a ventilation. I was just wearing a mask. And I remember all of a sudden getting a really, really, really nasty, nasty headache. And it came on really fast. Normally when you get a migraine or a headache, it comes on over maybe a half hour to an hour. Well, this was a matter of minutes, or even, I don't even know if it was minutes to a minute. And it just kept it got worse, and it got worse, and it got worse. And within a matter of a minute, because I was pretty much confined, I wasn't able to move really on my own at that point without assistance. I got this really nasty headache, and I remember I started to scream, because you're stuck in this bed, you're not able to move, you're not able to take care of yourself, and all of a sudden you get this really nasty, nasty headache. And I started to scream, and I was saying, I have a headache, I have a headache. And then it got even worse, and I started, at that point I'm almost blood curdling, screaming, I have a headache. And there was a nurse in the room, and I don't know whether she walked out to try to get help, trying to figure out what in the world was wrong with me, or if she walked out to get away from the noise. But she walked out of the room, and out of pure frustration, I pulled back the oxygen mask to really scream, and I passed out at that moment. And that was the last I remember of that part of it. And what had occurred was I'd gotten a morphine overdose. And morphine acts, and let me finish a little bit. When I came to, I had like people on my bed. There were easily 10 people in the room at that moment. And there was someone who was trying to stick something up my nose, and there was someone else doing something else. And I couldn't remember where I was and how I'd gotten there. And I remember, trying to stick something up your nose when you can't remember where you are and how you got there. You fight people off. And so I was trying to fight this person off who was trying to stick something up my nose. And I looked over, and there was a guy standing in the corner who looked familiar to me, but I couldn't place him. And he looked like someone I should know. And he was my surgeon. And what happens is opioids, the pneumotoxic center that controls your breathing rate, ultimately, my breathing was slowing down and slowing down and slowing down. And the other thing that's involved here is your breathing capacity. So rather than regular breathing contractions, your diaphragm starts contracting a little less, little less, a little less, little less, to the point of where things just slow down and stop. And that's what happened there. And obviously I didn't understand that all at that moment. The fun thing about learning about physiology is that you start to understand why things happen the way they happen. And I came out really disoriented. They were worried about brain damage, which explains a lot of things now. But, but I obviously I came out of they deemed me as being functional once again and couldn't measure any brain damage. But the reason I bring this up is because one thing that I can tell you is if anyone ever tells you that suffocation doesn't hurt, it's exceptionally painful. And talking with my mom about it later, because she wasn't there at that moment, she said that what it's called is an anoxic headache, and they come on and they're really severe and they're very intense, and they're usually a frontal lobe headache. And at this point, you know, this is 20 years later now, and I can't remember exactly where I felt that headache. I just remember that it came on very quickly and it was very intense. And it's really kind of scary. But yeah, I just received a morphine overdose. And one other thing that happened with that was kind of interesting is they put in an arterial line. And what that means is that they inject a catheter directly into an artery so that they can measure your blood pressure and your oxygen sat levels. And from what I've been told, they're supposed to be exceptionally painful. And
They are.
they are? I don't remember feeling a thing when they put it in.
Are you lucky?
But I have I refer, you know, I have two little tracks on my wrist. And of course you can't see me at all. Let's see if I do something really quick, if this will start to work again. Of course, it's still not working. Why am I not there? I don't know, but I have two, I refer to them as my drug tracks. And now my screen is blank. I'm not, I apologize. I don't know why that's happening. But from what, I don't even remember it at all. I don't remember them putting in that line, but I know that's what one of the people was doing that was on my bed when I came to. One of them was trying to stick something up my nose, which was not great because I was so disoriented. And the other one was putting in an arterial line. So yeah, just an interesting adventure, but I only really understood that. I started researching it out about a year ago, what opioids do to your breathing. And that's where they impacted it, is the pons in the medulla oblongata. So coming back off that tangent, the midbrain is going to form from the mesencephalon. And it's going to contain the cerebral aqueduct. And it's going to be surrounded by a central gray matter that's involved in controlling pain. It contains the nuclei of two more cranial nerves, the oculomotor nerve, cranial nerve number 3, and the trochlear nerve. Both of these nerves are involved in eye movement. The cerebral peduncles, the little feet, let's see, where are they? Right here. Here's the thalamus. Here's the cerebral peduncles. They look like little feet kind of holding up the brain here. are little structures on the front of the midbrain that arise from the front of the pons that contain large ascending, sensory, and descending tracts that run to and from the cerebrum of the pons. So these are two midbrain stalks that are going to anchor the cerebrum on the brain stem. So medulla oblongata with the pyramidal tracts, the pons that contain a lot of your respiratory and your cardiac centers with your medulla oblongata, your cerebral peduncles. So this is looking at the anterior surface. This is looking at the posterior surface because here's the cerebellum. So the cerebellum in this picture would be right behind here. About right here. So to keep us oriented here. So the right behind these little bumps, which we'll talk about right now, are the cerebral peduncles. These little things. So on the opposite side here are these bumps. Go tell her, go get her, go get her. These four little bumps are what we call the corpora quadrumana. And I know that you can't see me anymore for some reason. How many of you immediately looked up at the screen when I did that?
Yep.
You.
If you didn't, just say you did. But what that is a reflex of yours, that when you hear a loud noise, you look towards that noise. It's the startle reflex. When you see something that's maybe borderline offensive or graphic to your eyes and you keep staring at it, or you're tracking something that's moving with your eyes, the superior colliculi are involved in visual reflexes, being able to track something that's moving. Staring at something that's rather intense. That's superior colliculi's function. The inferior colliculi are going to serve as reflexes for auditory stimuli and include the startle reflex. When you hear a loud noise and you look towards it, that's the inferior colliculi. Also within the midbrain is the substantia nigra, which produces dopamine. It's responsible for relaying messages that plan and control body movement. What's dopamine, guys?
Brain.
What?
It's a chemical in the brain.
Well, what's the function of that chemical in the brain?
Does that feel good? Like feel good?
It makes you feel good, but what
yeah, I was
is
gonna say
what
it's the
is-
feel good.
it's the feel good chemical. But what? Tell me a little bit more about it. What do we know about it from chapter 12? What is it?
Is it like a sensory?
Yeah, but what, it's sensory, but what kind of chemical is it? It's a sensory chemical, but what do we call those chemicals in the nervous system?
Endorphins? No.
It
I can't
kind of
remember
is.
the-
What? It's a feel-good chemical. It's kind of an endorphin in a lot of ways. What do we call those things?
A monoamine.
What?
A
A monoamine. Well, what's a monoamine? What in general, what is a monoamine? A monoamine. What is an acetylcholine molecule? What is serotonin? What do we call all those? Not hormones, but
The-
what?
I feel like it works with the endo.
It works with the endo. It's similar to the endo, but it's not exactly, because hormones tend to move in the bloodstream.
A
These aren't gonna-
neurotransmitter.
Neurotransmitter, exactly. So
Yay!
good job.
I was like, yay, good job.
Okay, so the substantial, so the substantia nigra, it looks black. That's where the word is coming from. And it's going to produce dopamine that's responsible for relaying messages that plan and control the body movement. One thing that's really important about the substantia nigra is that it relays inhibitory signals to the thalamus and the basal ganglia that's involved in motor movement to suppress unwanted body movement. Keep that in mind. Suppress unwanted body movement. You want to fine tune your movement. So I have a pen, and I wish you guys could see me, but I have a pen, and the dopamine, the substantia nigra, and the basal ganglia are going to be involved, that when I see the pen and I want to grab the pen, I'm not going to reach behind the pen. I'm not going to reach in front of it. I'm going to grab it. Does that make sense? So if I have a pen and I want to pick up a pen, I'm not going to pick up somewhere past the pen, try to pick up something that's past where the pen is located or before where the pen is located. I'm going to be able to pick up the pen. Keep that in your mind for one moment, because I want to get through this before we end class really quick. So Parkinson's disease is a degenerative progressive disorder that affects the neurons in the substantia nigra. Well, what does the substantia nigra do? It's responsible for relaying messages that plan and control body movement and relaying inhibitory signals to suppress unwanted body movement. What the result is that when the neurons of the substantia nigra start to degenerate, they're going to release less dopamine. We're not going to be able to suppress those unwanted body movements as easily. Is that making sense?
Mm-hmm.
So when you're trying to reach for a pen, you all of a sudden can't pick it up because you can't fine tune that movement to where you can pick up that pen. So this disorder tends to lead to shaking, stiffness, and difficulty with walking, balance, and coordination. Which statement is false about the medulla oblongata? You guys,
B.
say it again.
I think it's B.
Why do you say it's B?
Well, because I believe it's not A or D.
Not A or D, and is it C?
I don't know.
You're right. It's not C. You're right, Wendy. It is B. So
Okay.
first, one of the ways that you can determine this is what are the nuclei in the central nervous system? They're the cell bodies. Are the cell bodies white or gray matter? They're gray matter. So the nuclei of the medulla oblongata can't be masses of white matter, right? Because the neuronal synapses are all gray matter. But Wendy's right, because the medulla oblongata does have the cardiovascular center. It does have the nuclei that are involved in coughing, swallowing, and sneezing, and the medullary rhythmicity center. Let's end right there. So we're first, do you have any questions?
No.
Okay. My goal for next time is to finish this chapter 14. But let's stop right here for today. We had some pretty interesting discussions. So I'm glad of that. I hope you learned something. Have a wonderful weekend.
You guys as well. Be
You
safe.
too.
Thank you.
Be careful.
You too.
See ya.
Bye. Have a good one.
You too.
Bye.
I have a question about the quizzes.
Yeah.
So
Go
I
ahead.
have on chapter 7, the bone tissue, and chapter 12, the nervous tissue. I
Yeah.
have 2 zeros there, and I did email you about chapter 12. I missed that one, but then took it like a couple days later. And then chapter 7,
Uh-huh.
I was looking through the actual book, and I have a grade in.
Will you Preston, will you send me a screenshot
Yeah, sure.
showing that grade? Did you get a grade for the chapter 12 quiz?
It's no, I don't think so.
Okay,
It's what I
if you,
emailed you about, but then took it like after I sent that email.
okay, go in and make, if you have quizzes that you don't have scores for in D2L,
Okay,
send me a screenshot showing the title of the assignment and the score you received, and I'll update your grade.
awesome, thank you.
Of course.
I'll email that to you.
Yeah,
after I send that.
you know, sometimes, you know, D2, having McGraw-Hill connected with D2L is great, except when it doesn't work. And
Yeah,
every once in a while, it doesn't work. So yes, just send me a screenshot and I'll update it.
okay, cool, thank you.
Of course.
Have a good day.
You too.
Thanks.
Shakira or Ariana or Lydia or Levi, are you here?